Minutes.
Thank you, Mr. Chair, and thank you to all the witnesses for your testimony today. Dr. Vigot, I'm going to direct most of my questions to you. As you know, in May of 2023, the Government of Canada announced funding for 3 projects related to maternal mental health, one of which was Health Canada's funding of about $372,000 to Women's College Hospital to develop national clinic guidelines for prenatal mood disorder. How did this funding help the Women's College Hospital advance the development of national clinical guidelines, or perhaps support other initiatives in support of the maternal mental health?
Sure, it's my pleasure. So Dr. Van Lieshout actually referred to these guidelines. So this is a partnership between Women's College, but also an organization called CANMAT, which stands for the Canadian Mood and Anxiety Treatments, who have been doing the guidelines for depression, for bipolar disorder. Really, what treatments does the evidence suggest that we should be recommending? And so what we did with those guidelines, which I'm co-leading with Dr. Benice Geoffrey from McMaster University, is what we did was we developed a group of scientists from across the country who had expertise in this area. And we worked on also developing panels of experts that would help us. And actually, Dr. Montroy is on one of those panels. Dr. Hittman, will likely be asked to talk with us as well. But we have panels of research experts. We have panels of care experts like OBs and midwives and other psychiatrists who do clinical work. And we have panels of persons with lived experience, in addition to 2 persons of lived experience on the committee. And what we've done so far is we've actually done the evidence review, which started with 12,000 reviews of evidence that we systematically went through. And then what we do is we classify that evidence and we say, what evidence is there, for example, for various therapies, for various medications. And we are actually at the point, we had a meeting March the 1st, where we brought all of the people together from across Canada who are writing the guidelines to start actually putting forward the recommendations. And this week, we have our first writing draft together. So we are hoping that we will have by early June everything out to our partners. And we're hoping by early fall, we'll actually have a publication. What we're also going to be doing, though, is developing a guide especially for persons with lived experience and patients and their family members. And we're going to do that in co-development with persons with lived experience and their family members. And we're going to have a reference guide for providers, because the whole idea here is that, and Dr. Montroy spoke to this, this also has to do with the issue of how do we identify disorders, is we have to have some guidance so that we can develop standards on who are we supposed to be, what are these disorders, who are we supposed to be looking at them in, and how are we supposed to provide treatment? And then people know what they should be receiving. And then we can actually, in each province, we can actually measure, are we living up to the standard of care? And only once you measure can you then improve. So that's where we're at, and it has been really a privilege to be able to have some of that support, especially for the library services, the evidence review. It's more work than I have to tell you I ever imagined. And Dr. Van Lieshout as well, I just have to give a kudos, who's been reviewing all of the medications that we need to use, and I think has spent, I don't even want to count, hours are in the 3 digits, I'm sure. So that's what we're doing.
Well, thank you. That was a very comprehensive and very great update.
I'm sorry if I took too long.
No. Actually, that was great. I was hoping you get into some of the timelines, and I thank you for that. I only got about 30 seconds, and I'm going to be a bit partisan here. Can you talk about the importance of developing this national clinic guidelines to treat prenatal and reproductive mental health, as opposed to allowing provinces to create their own approach for the care of screening? You touched on that a bit. In your view, what role do you feel that the provinces should play? Thank you.
Well, as we know, the healthcare services are organized by province. And so what we should be able to do with these guidelines is we should be able to say, well, this is the recommendation for treatment. And, these treatments, let's say, are all available in Canada. I'm talking about therapies, medications, how quickly someone should be seen, et cetera. And then that might allow, for example, and this won't be under my control, but that might allow, for example, for the Standards Council of Canada to say, okay, so you've done these treatment guidelines. Now, what are the standards that need to be met, right? And then working in partnership with the provinces, they may be met in very different ways, right? So, within Ontario, we've just been funded to take 5 different hospitals to work together to actually start to meet some standards preliminarily, on our own. But different provinces may do it differently.
Thank you, Dr. Vigard. Suite, Madame Bérubé pour 2 minutes et demie, s'il vous plaît.
2.5 minutes, Dr. Bérubé. Thank you. I've got a question for Dr. Hipman. So when it comes to mental health disorders such as anxiety and depression, how can they have an impact on deciding to become a parent, and how can they have an impact on parenthood itself?
Sorry, I was a little quiet there with the translation. Your question was how can mental health conditions impact parents when they're desire to get pregnant and then as they're parenting. So I guess one story that comes to my mind, I worked as a psychiatric genetic counselor for a while, and I saw a woman who has bipolar disorder and who is very aware of all of the risks that are involved in getting pregnant, and was very concerned about her own mental health and knowing that there's a higher risk for postpartum psychosis, for example, when you have bipolar disorder. And so she was saying, I really want to be a parent, but I'm worried about, the pregnancy piece. But also I see that, adoption can, I'm maybe disadvantaged in adoption in terms of out of country, like they're not, wouldn't allow for it with my medications that I'm taking. There's within country, there's, if it's, would somebody choose to make an adoption plan with me, knowing my history, and then she was also worried about the risk of passing on the genetic vulnerability of bipolar disorder to children. And so she, we talked about it a lot, and ended up, I wrote a letter in support of her having fertility treatments and having a donor egg. And so she felt better about removing some of that increased genetic vulnerability to, pass that along. And then she had a really strong support team with psychiatrists and other mental health, allied health professionals to support her, and did very well in the postpartum. But I think it depends partly as well. This was a very well-informed woman, and others maybe don't have the same kind of insight and awareness and connections. So it would be, I think, really good to have additional supports in that area. And then it can impact, your capacity to engage in parenting. Obviously, if you're experiencing depression, as an example, then it's just everything's harder. But parenting is one of those things that's harder.
Thank you, Dr. Hipman. Next, Ms. Idlout, please, for 2.5 minutes.
Thank you. I'll be asking my questions to Dr. Leishout. Sorry if I mispronounce your name. I'm very curious about the recovered peers that you've been mentioning. What are some of the protective factors maybe that these individuals would have had to be able to become recovered peers?
Yeah, thank you. All we required was that they had recovered. They'd been recovered for more than a year, and then we asked them a few questions just about their openness to different treatment approaches. What we wanted when we were selecting people that were going to work with mothers who were struggling is then openness to everyone's experiences and their different treatment choices, so that those participants could feel good about that. And one of the things that we found, I mean, one of the singular joys of my career has been working with these peers. They are remarkable women, remarkably strong and bright and committed. And one of the things we found when they were trained and then delivered the therapy and then supervised each other in delivering the therapy to make the program sort of self-sufficient is that they found that engaging in the helping work helped them solidify and complete their own journey in recovery from depression. So some people were worried that they were going to get worse, but treating others or helping others actually led them to feel stronger and more recovered.
Could you give us a better sense of the context of these recovered peers, like about how many were considered recovered peers, and what is the possible expandability of using individuals such as recovered peers?
Yes, so they ranged very widely in age. Some had just recovered, some were in their early 20s, and some were in their 50s, having had their reproductive journeys 30 years ago. And so we weren't very particular when we were selecting them. We were interested in people from all walks of life and all experiences, and so we were really inclusive when we selected them. And they came from all walks of life, spiritual orientations, things like that. So there is unfortunately a really big supply of people who've recovered from postpartum depression, unfortunately, because it means they've gone through it in the first place. But if 1 in 5 have gone through something like this, we have a really large supply of recovered peers who could help fill the gap that exists in terms of getting people treatment in a timely way.
Thank you, Dr. Van Lieshout. Ms. Idlout. Next, Dr. Ellis, please, for 5 minutes.
Well, thanks, Chair. Just give me a minute, if you would, witnesses, to indulge some committee business. I'd like to give notice of the following motion, that the Minister of Mental Health and Addictions has asserted that there is no evidence of widespread diversion, and yet the Canada data released today shows that police seizures of government-issued hydromorphone in British Columbia has increased fourfold, or 300%, since the implementation of safe supply, from less than 100 seizures per year to 408 seizures in 2023. The Prince George RCMP reported the seizure of thousands of safe supply pills in an illegal drug bust of 10,000 individual prescription pills last month, and police in Campbell River, BC have reported the seizure of 3,500 diverted safe supply pills on the territory of the Wee-Waa-Kay First Nation. The chief of the Wee-Waa-Kay First Nation has harshly criticized the so-called safe supply experiment. 3,656 people in British Columbia have received government-issued hydromorphone because of this dangerous experiment, and that there have been reports of diverted safe supply drugs being sold in schools. That the committee call the following witnesses: the Minister of Mental Health and Addictions and Health Canada officials for no less than 2 hours, RCMP Commissioner Michael Duhem, Assistant Commissioner John Brewer of RCMP E Division. That's the end of my statement. Thank you for indulging me. I appreciate that. Dr. Hittman, when we first started talking about this, I'm wondering if we might make it clear to all Canadians out there listening the difference that the Canadian Task Force on Preventative Health, the change in the recommendation, because I think maybe a lot of us here knew what had happened, but to explain to Canadians in the easiest way what this really means, I think I don't want people to miss out on the difference this change means to Canadian women out there.
In terms of you're talking about the task force recommendation that came out in 2022.
Yes, sorry, doctor, thank you.
Yeah, that's okay. So when that was released, it actually was consistent with the previous task force recommendation that was focused more generally on depression in, I think, in women or in adults, that was still recommending against tool-based screening, so using sort of a questionnaire, basically, and suggesting that what would be better is a conversation with your doctor. And so the recommendation, basically, the change that we saw at the BC Reproductive Mental Health Program was that was released, and then we heard kind of informally from like OBGYN colleagues or family doctors, oh, so I don't need to worry about screening anymore. And so even though that wasn't technically what the task force recommendation was, what was heard, generally speaking, by maternity care community was that screening for perinatal depression was not recommended.
So in essence, though, Dr. Hittman, I mean, realistically, I think we've heard from all of our witnesses today very clearly that during this perinatal period it's a unique time in life, obviously, for many reasons, but it also presents an opportunity to screen for mental illness and difficulties that we heard very clearly, I think, can affect the pregnant woman and the child, subsequently, of course, relationships in there. Yeah. So, and just to be clear for people listening, that the unintended consequence of this recommendation was that screening is not being done. Right. Am I clear on that?
Yes. Yeah.
Okay. And so the recommendation now, what would you like to see differently? Do you want to return to that tool-based screening? I mean, often medicine's about a relationship, of course. That makes it much easier if you've known the person. But as we know, many people don't have access to a family doctor. So if you had all the money, you had the $4.5 billion of the Canada Mental Health untransferred money, what would you do? What would you do differently?
Thank you. What a dream. Yeah, I would, so just at a very small scale, it would be great to have universal standardized screening be recommended. And what I mean by that is to have a clear message sent to all primary care providers that this is important, that yes, there's nuance in how you do it. So if you use the gold standard globally, that's called the Edinburgh Postnatal Depression Scale, you can use that, but you can make it a part of a conversation. It doesn't have to be like handing someone a piece of paper and, so you can incorporate that into your regular practice, but it's the strong message is ask people about their mental health to see whether there's depression there. And then if I had the additional latitude and money, then it would be wonderful to see some of these other recommendations that you've heard today in terms of having more of a national strategy for perinatal mental health that would enable additional training and capacity for healthcare providers to know, how to best support people, how to connect them into all of the amazing supports that are out there, but as we heard, are not necessarily connected.
Oh, well, excellent. Thank you, Chair. And I guess the question then remains is, when we look at this, we know that 25%, maybe a third of Canadians have issues with their mental health generally. I think today we heard very clearly that pregnant women have perhaps more issues. And almost half of people now have unmet health care needs. And maybe I'll give a shout out. I met with the Canadian Association of Occupational Therapists today, and I think that they would be ideally suited to provide part of this care. Is that a fair statement?
I think that would be great. Yeah, be fantastic. I'd also love to see a role for psychiatric genetic counselors to support.
Excellent. Well done. Thank you, Dr. Hittman.
Thank you, Dr. Hittman. Dr. Ellis, next, Dr. Pawlowski, please, for 5 minutes.
Well, we're all a very sophisticated bunch here, so I'm kind of surprised no one's asked some real dumb questions, so I leave it to me. I'm not a common sense conservative like over there, so I lack that. But I would have thought that, and as I recall in medical school, the big issue around perinatal depression, isn't it that there is a societal expectation that people are happy? The husband thinks that or whoever the father is thinks that the mother should be happy, the siblings figure they should be happy, their parents think they should be happy, and they're not. And I would have thought that's part and parcel of the whole problem, is that there is this expectation you're supposed to be happy, that kind of, perhaps some shame and unwillingness to talk about it because you're supposed to be happy. So with that, I had two questions. One is why? Like, how much is it hormonal? Is it, I'm sure it's a large number of cases because there's pre-existing depression. But how much of it is other things like the situation the woman's in? She's unhappy in the relationship, loss of freedom, lack of support. So how much of it is situational? How much is hormonal? So that's one of the questions as to why. And then the second part of the question is, how much is that part and parcel of the whole problem in recognition and treatment, is the fact that there is this expectation you're supposed to be happy?
Because we developed this program that I referred to before, which is called, it was inspired by Mothers and Babies, which is evidence-based really worldwide, but stems from Santo Alto in the US. And we adapted it to call it Toi, Moi, Bébé, You, Me, and Baby. And one of the first couple modules is really that. It's just basically like we made these kinds of cartoon BD, like we call them in French, and we were basically just addressing a lot of these societal sort of universal golden rules of how, like when I was saying before, of how people experience transition to parenthood. It's not the same for everyone. And I think a lot of the times there's these sort of social standards that are sometimes perpetuated by what we see more actively in the media. And so therefore, I think this is very helpful. People that we've worked with, we've had them test out the intervention at the very early stages in terms of feasibility and acceptability. That's one of the things that they would point out. I felt so relieved to actually see, a woman that was experiencing pregnancy in a positive light, but then there was also a representation of me where it's been very challenging, and it's not like, it's not a joyful moment. So I think, until we really know, like, to get to your second question, the why, I think there's nothing that prevents us from actually just having these types of interventions available, because they do seem to help, right? And they're easily accessible, for example, in our province online. Now, the other piece is that there are, like, for example, studies like ours, like MOS, the Montreal Antenatal Wellbeing Study, which we're looking for, like, certain biomarkers. One of them, neuronal or, so endocrine. For sure there's something happening. We know there's specific profiles of women that are more vulnerable. And so therefore, when we're talking here, it's more about, women's health more generally, but preconception care, for example, brings about this opportunity to maybe, if we were to identify these biomarkers, we're able, in combination with just the dialogue and picking up on certain things that are being mentioned by the pregnant people, to also have these more medical and based biomarkers. What I would really want to maybe just quickly add is that, as a clinical psychologist, what I see is that people that are not expecting, they oftentimes neglect their well-being. We're all like that. We know what healthy lifestyle is, and we don't necessarily do it. Why pregnancy for both women, but also fathers, men, presents as an opportunity is that all of a sudden, I'm preparing to not only care for myself, but for my offspring. And there's something that happens at the cognitive level and the motivational level that people want to seek help. And so therefore, why not leverage this added motivation to actually get people to talk about mental health and how they can do a self-reflection at that moment to improve themselves according to not a curative approach, but more a preventative one. And we've already heard stats from Dr. Ryan Ventura about like the 1 versus 7 for every dollar invested. This is Dr. Heckman going back to 2000, which mentioned this. If we were to invest $1 in prevention, for example, it would cost us $7 in terms of curative care later on. So, I mean, this is what I think we need to keep in mind. There's an opportunity to use those motivational aspects to get people to want to get better.
And I don't know if there's any time for me to add a little bit, just that even before we have the biomarkers or anything like that in a blood test, even right now, as a genetic counselor, I take family histories, and you can tell a lot based on just what's happened in somebody's family for their risk. And you can work with them, part of genetic counseling is identifying risk, but it's also talking to people about things that they can do to protect their mental health. And so there are ways that, we've seen improvement in mental health for people after they've come for genetic counseling So there's a mix in terms of genetic vulnerability and the environmental.
Thank you, Dr. Hipman. Next, we're going to go to Dr. Kitchen, please, for 5 minutes.
Thank you, Mr. Chair, and thank you all for being here. It's greatly appreciated. And, you know, ultimately, we're doing a study here that we can try and hopefully go to Canadians and say, how are we going to make it better for women? And it's a challenge. And you all are researchers. And you've indicated that to us. And I thank you for the research that you do, because that helps practitioners. And it helps some of us at this table have been practitioners. But at this point in time in our life, we're politicians. And ultimately, how do we improve things for Canadians, especially when we're dealing with a healthcare system that is primarily a provincial issue? And there's a huge challenge along those lines. Now, I know throughout the conversation we've had today, we've talked a little bit, and very quickly, everything's being talked about postpartum and peripartum, et cetera, being 1 year. And I would argue that that's not the case. And I think people listening here would turn around and go, well, it's a 1 year, so I'm a year past my birth, I don't have to worry about it. And so I would just quickly, is there any evidence to suggest how long it could be? Dr. Montreal.
Yeah, so that's a very good question. I mean, we do know from, let's say, and I think more and more when we develop protocols to be able to follow that, that's one of the things, right? Those kinds of if we were to have a continuum of care from preconception going forward, we'd be able to really establish these very strong causal models to address the question that you have. But unfortunately, we have a lot of sort of cross-sectional studies at different time points, and we can kind of put these kinds of studies together. One thing we know for sure, for example, for some of the studies that we're conducting at the RIMUHC, is that essentially, for example, in the case of anxiety starting perinatally, we do know that there is some sort of linkage, for example, with conditions that are inflammatory, that can then, for example, once we get these women at their first pregnancy, if we follow them into their second pregnancy, it seems that, you know, if you were to look at these two pregnancies in more than just a year, there are connections. So, for example, the mental health that remains unaddressed will also affect.
And I appreciate it, and I apologize for cutting you off because there are a number of questions and I have such a short period of time. Dr. Van Lieshout, and I apologize if I pronounced your name wrong, you talked a little bit about lactation and concerns about medications and issues. How do we educate Canadian women to truly, because today's world, and I know when I was in practice, Dr. Google came into my office every day and said, this is what I've got. And Dr. Google seems to know that a lot more about what goes on in lactation than supposedly practitioners do. And I'm just wondering, how do we combat that?
Yes, I'm familiar with Dr. Google and their credentials. So I think the first thing is when we put together these practice guidelines and we get the state of the art in Canada together, and then we get that information out to the frontline practitioners so that they know this, so that when people come and ask those questions, when they seek a second opinion on Dr. Google, then they have that information handy and they can help those people make the best decisions possible. Same with the midwives. So we look forward to doing that with the information that we're pulling together now. And then, you know, I think we have to see how that goes. Maybe there's room for public health to get involved and start to talk about all of the real benefits and drawbacks of treatment versus not getting treatment. And unfortunately, in Canada, with the shortfall of psychotherapies, they're not being available. Medicine's often a default option for a lot of people, and people just get no treatment as a result because of the uncertainty about the safety.
Thank you, and I appreciate that as well. And ultimately, I think when we look at aspects of what we're dealing at, you brought up a point, and I come from rural Saskatchewan, and my colleague from the bloc, she comes from rural Quebec, and my colleague from Nunavut comes from much farther. So my rural, which I consider rural, is not even close to my colleague from Nunavut. And my colleague beside me, who comes from a rural area in London area, ultimately it's a half-hour drive. But we have 2-3 hours for our constituents to get to where they are. And our female constituents, where they're dealing with practitioners who are coming from various parts, who've never lived in that area. And now, how do we educate those practitioners to make certain that that information to women is being put out during that time, such that they know what to do? Because driving 3 hours to go for a meeting, and as you said, Dr. Montreal, the reality is focusing on an issue of focusing on on the baby as opposed to focusing on the mother is a big challenge. How do we improve that?
Can I jump in?
Certainly.
Is that okay?
Please.
So one of the things that we did is because, if you go on Dr. PubMed and you type in antidepressants in pregnancy, you'll get like 80 articles a year, right? So for practitioners to go through that is like practically impossible. And then when patients type it into the internet, it also is. So one thing that we developed a number of years ago is we created an online patient decision aid, which actually talks to people about, this is what your condition is. These are the potential benefits of taking. These are all the different treatments. These are the potential benefits of the medication. These are the potential safety risks. And then we tested it. And we were able to find that somebody who did the talk to me, like in my clinic, because I'm a provider and I do these kinds of counseling all the time, that, the decision aid didn't give much more to them. But when we tested it with people across Canada who, for example, lived in rural Saskatchewan and other places, they really had a big improvement in their decision-making difficulty and felt it was so much easier to make a decision about whether to use the medications or not. And then we were funded, actually, we've just completed about 500 people all across Canada to see not only does it help their decisions, but does it help them actually have better outcomes and have less likelihood of having depression in the long term. So I think there is something about, if you can take the few specialists who then with a trustable brand with the evidence, then there are really neat ways of getting it out to people. And with the tool, the family doctor can download it, the patient can look at it. We have really good technological ways of getting that stuff out. But I think it's about making sure that the information is branded in a trustable way.
Thank you, Dr. Vigod. Next, Ms. Thompson, please, for 5 minutes.
Thank you, Chair, and I'm so pleased to be here today. I'm not normally part of this committee, but I have to tell you that what we're speaking about is very near and dear to my heart. And in my riding of St. John's East, there's tremendous work happening. It's not clearly where we need to be, but this is something that I'm very aware of and certainly continue to worry about. And there's a mother and a nurse and now in this role as a politician. I want to, Dr. Vigod, if I could just go to you, and it really could be asked of anyone in the room, go back to step care. And if you could drill down just a little bit more, because in the back and forth, I still feel that there's not a real understanding of what step care is, and then the role of the multidisciplinary primary health care in enabling someone to begin the supportive treatments without having to see a family physician. So could you really break it down for me, please, in a really simple, tangible way?
I can try. And then maybe my colleagues will help me with that a little bit. So the whole concept of stepped care is the idea that you would want people to be able to have treatments that are you would want people to be able, if they have very mild symptoms, you'd want to be able to give them the kind of least invasive treatments first and the ones that are most easily available. So, and then you would only want them to have you would only want to add on another higher step, something that is either takes more resources, takes more of their time, or maybe has more safety issues associated with it if they really needed it. And so what we normally think of as the step one of care for perinatal mental health is we're talking about education. We're talking about, self-guided treatments. We're talking about public health nurses' supportive counseling. We're talking about what we talked about today. There's so much evidence, for example, for peer support. Then if people, and for protecting people's sleep and dealing with all sorts of other social issues that are happening and support. And then if those things don't work and then you'd want to move to a next step of care that maybe involves a formal psychotherapy like cognitive behavior therapy or interpersonal psychotherapy. And then if that doesn't work, you'd want to move up another step, maybe to medications. And then, if something's very, very severe, you might be talking about hospitalization or different kinds of, kind of more serious treatments. But you also have to remember in stepped care is that depending on someone's level of severity, you might give them the step 1 things, but also realize they need step 2. Or if somebody is very, very ill, let's say suicidal, you would move them to step 4 right away. So stepped care really is about like what step do they need? And sometimes we can go up a little bit, but sometimes if someone's really sick, you might start them at a step 3. Does that help?
Absolutely. Thank you. And could I also then lead into the conversation around public awareness, and that really links into so much of the challenge and stigma, why women tend to hide how they're feeling in the perinatal period. What would a public awareness campaign program look like?
Well, from my point of view, we've talked a lot about perinatal mental health today. From my point of view, we should be talking about women's mental health across the lifespan and all of those different unique issues, because they're all related to each other. For women to even know that if you are biologically, if you're more likely to have mood problems around the time of your period, you're probably more likely to have mood problems when you deliver a baby and around perimenopause, right? It's all linked together. And what are the things that are different? Women should know that they might metabolize medications differently. So I think it's really about, given how many people struggle with mental health issues, we don't, a public awareness campaign doesn't need to talk about mental illness or mental disorders necessarily, but can talk about mental health issues across the reproductive lifespan so people can understand, what is kind of par for the course, but what should suggest that I might need a little more help. And if I need a little more help, what are the things I can expect from my treatment? And that's actually where I would start. Of course, I do 80% of what I do clinically is perinatal. The others here also, could talk about perinatal. You could think about, very specific things, but that's actually where I would start. I think even if we had more awareness about women's mental health more broadly, when you got to the perinatal period, people would be, sort of more willing and more able to realize, that they might be able to, that some of the shame and stigma might help. So that's my view. Others may have different ones.
Thank you.
Thank you. Thank you. That's your time.
Oh, it's my time, Darren.
Yeah.
Thank you.
No, that nod meant you're done, not keep going. Yeah. Good. Yeah.
I tried.
Yes, no, it's fair. I didn't explain it from the outset. Madame Berube, 2 minutes et demie, s'il vous plaît.
2.5 minutes, Madame Berube.
Donc, ma question va être au docteur.
So for Dr. Lieshout, what about the risk factors and mental health protection? Is that useful during a woman's life, in particular in different phases, such as during the menopause?
So I was listening to the simultaneous translation. You asked about risk factors for mental health across a woman's life, and does it change over period, menstruation, pregnancy, postpartum, menopause. Yeah, so, I think it is true that the risk factors around having a history of depression or a family history of depression or a mother or a sister who struggled with reproductive life events, that is a risk factor. Some women's brains are more sensitive to the hormonal shifts. It's not necessarily a high or a low level of hormones, but something about the shifting that some women's brains are more sensitive to, so that's a risk factor. The other risk factors are some of the things that I talked about. So, for example, early childhood trauma, physical, sexual, emotional abuse is a major risk factor. And then others, psychological and social risk factors, losses, transitions, when related to the menstrual cycle, sometimes people, if they're in more stressful months, it will actually impact the premenstrual mood. We talked about the perinatal period, not only the biggest risk factor for perinatal depression is lack of social support, lack of emotional and practical social support. And then when you think about the perimenopause, you're talking about transitions there as well, right? People are, getting closer to ending careers, children are leaving the home. So there are really very similar risk factors and kind of, I would argue, women-specific risk factors.
Selon vous, quelles sont les mesures?
So which measures should be taken by the Canadian government to promote good mental health amongst women during these different life stages?
I think I would say again that the biggest thing that we could do federally is to help women understand what they could face so that they know what they can expect from their mental health and they can expect from their treatment, and that they can understand that actually there are some very specific things that, there are actually different ways that we prescribe medication if somebody has trouble with their moods around the time of their period. Around the time of menopause, we get involved with the reproductive endocrinologist and the gynecologist because we have to think about, should this be hormone treatment or a different kind? So it really is, I think the awareness is important. And then I think the second thing is, again, the education. So we've got 50% of people approximately in the country are women, and yet it's not really in the core curriculum of training programs to talk about these women-specific things. Even like what dose of medication we should prescribe. We don't talk about that women absorb it more slowly, so it might, fill up in their, in their system higher and give them more side effects. I think we know these things, but we haven't. The federal government could help us with integrating these things better as core components of curricular training. And then finally, always more and more research about that attends to sex and gender.
Thank you, Dr. Vigard. And next, Ms. Idlout, please, for 2.5 minutes.
I'll ask my questions to Professor Vigard. I represent 25 communities that are all fly-in communities, none of which can be driven to. Out of the 25 communities, there's one hospital, and most of the communities only have nurse practitioners, a health center, and most experience closures will only open for emergency situations. Having understood some of these realities, I'm wanting to point out that there are too many risk factors for Nunavut, for women of Nunavut. What are the investments that this federal government needs to make to increase protective factors so that Nunavut women could enjoy the same protective factors that other Canadian women experience?
We speak a lot about, the social and physical environment elements that underlie health, right? If people don't have the basics of what they need, then it's very difficult. Even in my practice in downtown Toronto, let's say somebody who's coming to me and saying she doesn't have enough food to feed her baby, or she doesn't have anyone to help her, let's say, at all. I'm not going to make her better with therapy and an antidepressant, right? So I think, I would not pretend to have all the answers, but I think we're back down to what are these risk factors and how do we ensure that people have the basics of what they need, in order to be able to then build upon that and to have wellness.
Could you give an example of some of those basics? Would you agree it's something like having safe, comfortable homes, having a place to do homework, having a place to take care of your mental health?
Absolutely.
Thank you, Ms. Idlout. Next, Ms. Vecchio, please, for 5 minutes.
Thank you very much. And I am just going to go back to, I put you down as Dr. Vigan. I think that is, I just wanted to ask you, you mentioned about the online patient aid that you have available so that we don't all go to Dr. Google. Is this something that's available to all women or just people that are patients within your center?
So the idea is that it will be available across. We've actually finished the clinical trial now, so we're actually just talking. We're talking actually with the Quebec government about French translations, and we're talking now about how we can start getting it out sustainably. So hopefully, we will have it available pretty soon.
That's fantastic. And just a question, because I think I come from the dental health field, and I know that we used to have patients come in all the time, and you'd say, that's a sinus infection. And the reason you would say this is because I understand that dental really was about a 1 or 2 days of the entire curriculum. So when we're talking about mental health, and when we're specifically talking about women's mental health during this period, the perinatal care, what type of training would a general practitioner have during those first few years of school?
Well,
you go right ahead.
Answer?
Go ahead, and then I'll go around.
There is a little bit in the core curriculum in medical training. Dr. Montroy might be able to talk about psychological training, Dr. Hittman about genetic counselor training, but I would say that there are a paucity of hours relative to the proportion of the population that is affected.
Dr. Hittman and Dr. Montroy?
Agreed. I have worked to create some curricula for genetic counseling programs on perinatal mental health and mental health generally, and it's still something that is a very small number of hours.
I mean, we're testing it with the ECHO program right now. It's 6 sessions, really. So we're looking at, say, 90 minutes. So, I mean, it's possible to already increase the level of knowledge. And it's not just knowledge, it's the know-how, right? Sometimes it's just validation of some information that maybe people have gathered themselves. But having it in the context of a formal training really is enough to empower people to feel better with what they're doing. So given the time that it's limited, I mean, there's existing programs out there, and we just need to basically look at what's been done. If we look at the ECHO program specifically for the perinatal mental health, for example, one session is on screening and referral, and who can do the screening and referral. We're talking about sort of like more rural areas. Well, we have a screening and referral protocol that we're now testing with midwives, which has been shown to work really well, and we're thinking it could be adapted to other types of health care professionals. So I think there's a minimum. Like, for example, what is mental health? Like, how do I detect it? Like, what are the tools? These types of things. And I think it's enough to just give people information. And I think one thing that we're realizing as well is, our own biases with mental health issues, because one of the scales that we have is we're looking at change with our screening and referral. We're looking at, by educating people on just very basic few hours on we have a 3-hour training. We're able to show that just by giving a 3-hour training, we're able to change the way people feel about mental health. And that, I think, is a big piece that we're often omitting. We're just giving tools, but we're not looking at the beliefs that people hold about people that consult for mental health issues. And if we're able to change the care workers or care providers' views of mental health, we're able to improve the quality of the care.
Perfect. Thank you so much. And kind of going off what Lori said, 25 fly-in communities, and they need the services. Everybody needs these services available for them. But then we also have connectivity issues in those types of places. So what are some of the things that we can do between now and the time, now and tomorrow? What can we do immediately to help make changes for those people that deserve this support?
I think politically charged, but universal basic income, like having, more financial stability, and that would speak to food insecurity and, a lot of those basics that have that foundational wellness, and that can then enable, additional insights, and that's, education. I think a lot of those things can be implemented now, in terms of how do you take care of yourself and how do you promote your own mental health. That doesn't need anything additional, but you need to have the resources to feed yourself well.
Perfect. I know my time's out because I know he's cutting me off. Thank you so much for coming today. This has been so useful. Thank you.
Thank you, Ms. Vecchio. Et le dernier tour des questions, c'est pour...
A last round of questions now. Madame Forti. Thank you very much, Chair. And I'm also visiting the committee today, but it's been a great visit. I've been able to relive my 3 pregnancies, or 3.5, because unfortunately I had 1 pregnancy loss. But I was accompanied by a midwife And with all of the appointments with the midwife, they always asked about my mental health. That was part of the appointment. And even when I had my pregnancy loss, she continued to call me up to see if everything was going well. Now, I'm talking about several years ago, but nevertheless, this is still something that needs to continue. So thank you very much for sharing your ideas and recommendations with you. Now, I was really struck by this question of having a national strategy. I was able to do some quick research, and the Journal of Canadian Obstetricians last January came up with an article on perinatal mental illness. We need to act now together. So they referred to the need for a national strategy. And in the article, it says that Australia and the UK already have this type of national strategy. So what would it look like, this type of national strategy? And do you want to borrow from other countries? Well, it'd be useful to hear from you. And I'll start with Dr. Montreuil and then Dr. Hipman, please, on that. Thank you for that question. The national policy was adopted nationally in the UK and in Australia. I think the advantage of these programs, well, I worked on psychosis in my former life, and we often use the Australian model, Open Minds Access, which really helps to establish these links behind the medical community and the community context in general, so that we can create clinics that are easily accessible to people. So we've touched today on accessibility and availability, the need to have physicians. We've talked about remote regions where there are no physicians. What can we do? So many of these models, now I can't go into all of the details because it would be too lengthy, but we could give you these documents afterwards. Basically, there they have created true accessibility and established integrative links between the different players involved. I'd also like to say that we've realized that it's not enough to just do some advocacy. It's all fine and well to do that. But having worked with people with lived experience as well, sometimes psychological assistance and awareness-raising campaigns are just not enough. So that is one fear I've got as a psychologist. We do a great deal of psycho-aid, psycho-assistance, but there needs to be specific follow-up, real solutions. And I've got a person with lived experience who's worked with us who said the absence of solutions along with awareness-raising campaigns actually has a perverse effect, because over time people are saying, oh, it's normal, I should be fine now. And then there's the 30% who are not doing well. And that's where people start to say there's something really wrong with me, and they really turn to desperate means for these desperate situations. Now, Dr. Hipman, I see that you would like to add something. Please go ahead.
Yes, please. Thank you so much for the question. And I think the Australian example is a good one to look to. There's some similarities in terms of geographic distribution of the population, as well as the unique needs of the Indigenous Aboriginal populations in Australia. So I think they are a really good example to learn from. And they've also done a really good job of having evaluations of the implementation of their initiative, so the Australian National Perinatal Depression Initiative. They looked at what is the impact on hospitalizations for postpartum mental illness, and they showed a 50% reduction in psychiatric hospital admissions after they'd rolled out their screening and treatment pathways. And that is huge. I'm leading a research study right now with a group of lived experience advocates and advisors who have all experienced hospitalization for postpartum mental illness in Canada. And it is a really traumatic experience. Right now in Canada, there is no option to be co-admitted with your baby, so you will be separated. And it's something that we're hoping to work towards recommendations for ways that we can support do a better job of supporting people once they reach that level of need, in that stepped care pathway. But it really speaks to the value of trying to catch people early, get those foundational supports in place, and ideally prevent the need to have hospitalization.
Merci beaucoup.
Thank you, Dr. Hipman. Colleagues, that's it for the round of questions. We're just going to bid our witnesses goodbye, and then I have one question for you, so please don't run off. To all of our witnesses for being here, thank you so much. It never ceases to amaze the depth and breadth of the experience and credentials that appears before this committee, and today's panel was a shining example of that. So thank you for being so patient in sharing your expertise with us. Be assured that it will be of significant value to us in our deliberations. If there are any matters that you wish to augment to what you've already said, we are more than happy to receive written submissions. It will all be considered as we put together the report. So to all of you, thank you so much. You're welcome to stay, but you're free to leave. The one question that I have for the rest of you, colleagues, is the time has expired for the consideration of the Medicago documents that we had available for review. And so we would like the direction of the committee to destroy those documents. And so my question for you is can we have a motion from the committee to do just that? Is there anybody with any discussions, any points of view on that?
Motion to burn them.
Okay. If I may, I would like a motion that the unredacted copies of the vaccine supply contract between the Government of Canada and Medicago dated November 30th, 2020, submitted to the committee in response to the motion adopted by the committee on Friday, January 29th, 2024, be immediately destroyed by the clerk following the adoption of this motion. Anyone care to move that motion? Dr. Pawlowski, any discussion? All those in favor of the motion, please say aye. Aye. Contrary? No. The motion is carried. Is it the will of the committee to adjourn the meeting? Yes. Sure. The meeting is adjourned. Thank you.